Good morning for you, all of you who are joining us from the Pacific time zone, and good afternoon for those of you who are further east. I'd like to welcome you to our webinar today. My name is Janet Walker, and together with Eric Bruns, whom you'll hear from in a moment, I co-direct the National Wraparound Initiative, and this is the first official 2013 webinar in our webinar series. We're very excited to welcome you to the topic that we have today, using Medicaid health homes with wraparound to serve youth populations with complex behavioral health needs. We are anticipating a very large audience for today's webinar, so it's extra important that we ensure that things run smoothly. Perhaps the most important thing is that during this presentation, this is something of a change from our normal procedures. We are actually not going to be taking audio questions at the end. We've just found that there are too many difficulties with trying to run it through the audio. You can chat your questions to us using the box in your GoToWebinar panel at the side of your screen, and just type the questions there, and we will be kind of compiling all of those questions and asking the presenters to address those at the end. Some things that typically come up for people: you should know that we will be posting this webinar on the NWI website. You can see that on this slide, probably within 12 or 24 hours at the very most. We'll also be posting some other materials, so that, for example, websites that are discussed or other materials that are discussed during the webinar, we'll put up some information about how you can access those, so you can come to one place to get all the materials that you want. We'd also just like to remind you that this is a production of the National Wraparound Initiative, and we encourage you to check out the NWI if you don't know about us, and especially to become a member. And we're also, one of the benefits of membership that we can talk about right now is that we are anticipating a National Wraparound Initiative conference, and that members will be able to find out easily about all of the excitement around that. We anticipate that that will be coming up in October of this year, 2013. And I'd like to turn over the webinar to Eric Bruns, who is going to introduce today's speakers. Thank you.
Good morning and good afternoon. This is Eric Bruns from University of Washington School of Medicine in very foggy Seattle, as co-director with Janet of the National Wraparound Initiative. It is a great pleasure to be able to bring you this webinar today. I'd also just like to say that it's a great pleasure to be associated with my two colleagues who are with me here today. Sheila Pyrese of Human Service Collaborative, who has helped dozens of states across the country figure out how to make the most of our Byzantine financing systems for children, young people, and their families. And also Diana Simons from the Center for Healthcare Strategies, which for 20 years has been finding ways to better organize health systems on behalf of low-income Americans of all ages. As Janet said at the outset, we want to encourage you, Nancy, you can just go ahead to the next slide there, encourage you to join the National Wraparound Initiative. This is just our website, which you've probably seen. Be part of our community of practice, along with developing and disseminating training materials, fidelity tools, managing a community of practice, and this website, continual updates of the research base. We host this series of regular webinars. Today's topic is about how the wraparound philosophy and practice model can be achieved for children and youth with the most complex needs, behavioral health needs, via Medicaid health homes. Go into the next one there, Nancy. Today's webinar has an very close to an all-time record number of registrants. There were over 700 registered. We can see that there's well over 300 on the webinar right now. And this just reflects how critical the issue of integrating care for our most complex populations with the most complex healthcare needs has become. Questions about policy and funding and clinical approaches to integrating care and coordinating care are no longer in just health journals and academic journals. We hear these stories in the national news, NPR, the opinion pages of newspapers such as the New York Times that ran this editorial on September 10th of last year. Real quick, among the 334 of you here, let's just find out who is with us. We're going to launch a poll real quick, and then I'm going to do an introduction to the topic here for about 10, 15 minutes. So what best describes you? We're really interested in knowing who attends these different types of webinars and information sessions. So please select one. Are you a Medicaid agency representative, representative of a different public agency, a family member, youth, or family or youth advocate? Are you associated with a system of care project locally or in a state, or are you a provider or managed care representative? What best describes you? Go ahead and select one, and then we will take a look and see who's here and move on to our topic for today. Okay, so 85% have voted. At this point, it looks like we have public agencies and providers or managed care organizations well represented, followed by systems of care representatives. Medicaid agency representatives, about 13%, so that means that there's at least 40 or 50 of you, and then 7% family members or youth or family advocates. So that's very, very interesting. So we have a lot of good representation across several of these categories here today, in particular public agencies and providers. All right, so let's get into this. So we see how this topic of integrating care and the issues around wasted resources in our healthcare system has become such a huge issue. Go on to the next slide there, Nancy. What we have to remember is that even though we hear primarily examples in the news about adults like with diabetes or health disease, it's real important to recognize that certain populations of children and adolescents demonstrate the same patterns of waste and poor outcomes, wasted resources, poor outcomes, due to a lack of coordination of care. What health condition in general is most costly for kids? It's not asthma, it's not infectious disease, it's mental health and behavioral health disorders. Go to the next slide there. Arguably, serious behavioral health problems present our most critical need for better approaches to integration and coordination of care in children's health. So Sheila will talk more about this, but her research, for instance, shows that 9% of Medicaid-enrolled kids, the 9% of Medicaid-enrolled kids who use behavioral health services account for 38% of all Medicaid spending. Here in Washington State, we've been trying for years to improve care and reduce costs of care for children with complex needs and multiple system involvement. Some years ago, we saw just how stark this picture is when we learned that the very small percent, again, you're going to hear this theme over and over again, the very small percent of children with involvement in 2 or more systems, so 9% of all kids involved in public systems who are involved in 2 or more of those public systems use 48% of our children's mental health dollars. Go to the next slide there. What drives this disproportionality? Primarily, a lot of it is about out-of-home placements. In Washington State, what we found is that 68% of children and youth who are involved in multiple systems were out of home at some point in 2004, compared to only 14% who are only receiving services from one system, such as mental health or juvenile justice or child welfare. So this just speaks to the critical nature of how critical it is that we find solutions for the kids with the complex needs and multiple system involvement. Let's go to the next slide there. My job here, before Sheila gets into finding some financing and policy solutions, is to talk about the clinical and practice issue. Our job is to find better ways to coordinate care and prevent costly out-of-home placements for these youths. If we don't do this, our scarce behavioral health resources is never going to be able to prevent and intervene early to meet the needs of all children. Right? So we have to find ways to make sure that we are rebalancing the system, because we know that kids with mental health problems, 80% of them don't get the help they need. And as you just saw, much of our resources go into these kids with complex and chronic conditions and multi-system involvement. 25 years after the concepts of wraparound and systems of care were introduced, outcomes remain poor and costs high for these youths with complex behavioral health needs. Why are costs so high and outcomes so poor? Well, there's a lot of reasons, but here's just a few. The complexity of child and family needs. They have multiple problems that can't be solved by a single evidence-based practice. They have multiple and overlapping problem areas. Families have unmet basic needs, and traditional services, whether they're evidence-based or not, don't attend to needs holistically. They don't tell the system how to prioritize what to work on. Next slide. Overlapping with this is that families are rarely fully engaged in services. They see this kind of lack of coordination. They don't feel the system's working for them, and they're not participating actively. They're not engaged in the services and treatments that may be helpful to them. Next slide. And finally, we know that systems are in silos. They don't work well together well for individual families. They have oftentimes different missions, eligibility criteria, financing strategies, and the multiple systems will often result in a plan for each system and no coordination across them. Kids and families, we've done these studies. We've seen families with multiple plans of care, and if you added up all the meetings they had to attend to each month, it often added up to 47, 50 meetings that they had to attend each month with no one helping them navigate all those services and systems. Go to the next slide there, Nancy. There's a silo, yeah. So how do we get past the silos? This is the way that our traditional systems could be conceived of as looking. Like I just said, you have multiple systems, youth and family who may be interacting with several or even all of them, and with each of them you have your own plan, and none of this is coordinated with respect to cost, the nature of the clinical services that are received. Go to the next slide there. So in the wraparound practice model, and the wraparound approach, our goal is to bring the systems together, to blend or braid funds in a way that can invest in facilitators or care coordinators. Go ahead and go down there, Nancy. So instead of having multiple plans with each system that's involved, including the health system, the systems come together around the youth and their family to create one plan. Go down one more. The plan doesn't just include formal services and treatments, but also the investment of effort of natural supports like extended family, neighbors and friends, and community supports from neighborhood, faith-based communities. And go down one more. And so the idea here is that we have to find ways at a high level to blend or braid funds across these systems that can help, that can ensure that we're investing in facilitators or care coordinators, and often family or youth support partners as well, who can bring the representatives of the systems together as well as those natural and community supports. Ensure that there's one team and one plan with a small number of priority needs that everyone is rallying around. Go down one more. Next slide. So I don't have a lot of time to talk about the wraparound process here, but before we hear about some of the financing strategies and the opportunities that the health home provision provide, here are a few points that are worth making. First of all, Wraparound is a defined team-based service planning and care coordination process. This is not a service per se. It's a structured approach to service planning and care coordination. And it ensures, like I just said, that there's one coordinated plan of care and one care coordinator. The ultimate goal is to improve outcomes and per capita costs of care. Next slide. It's got a defined practice model that takes the youth and family through 4 phases of effort. And at this point in history, we now have very defined manualized methods of ensuring that those who are in primary roles in wraparound, like care coordinators, family partners, youth partners, know how to support the process through these 4 phases and all of the activities to be as effective as possible. Next slide. Caseloads of these coordinators is intended to be low. The process is undertaken with a level of intensity that is aligned with whether or not progress is being made towards meeting the needs of the family. And the process is undertaken until priority needs are met. Oftentimes it's about 6 to 15 months, what we find out there in community wraparound initiatives. So wraparound looks very different from uncoordinated or professionally driven approaches. It's characterized by high quality teamwork, a plan and a team process that's driven by and owned by the family and youth, taking a strengths-based approach. The plan focuses on priority needs as identified by the youth of family, and it's holistic. It takes a whole youth and family focus. Next slide. The theory, which is backed by research from across many disciplines, poses that the outcomes that are improved via two main pathways. So first, the services and supports in the plan work better because we're actually focusing on priority needs as identified by the youth and family and supported by the team. The plan is integrated, and there's greater engagement and motivation, not just on the part of the family and youth, but on part of the team members and natural supports and neighbors and family members to help the youth and family. The other path to more positive outcomes is that the process of wraparound in and of itself builds family capacities, such as the sense of self-efficacy, confidence and optimism that they can make a difference in their own lives, and increasing the social support that families and youth get, social support that often is not available for these families and youth because of the challenges that they face. Next slide. So clearly one of the biggest questions before we start asking how do we finance strategies such as wraparound and the continuum of services that need to be available and the workforce development efforts that need to be invested in is, does wraparound work? And at this point in history, the answer is that evidence from 9 published controlled studies is positive. There have been studies of wraparound across the different systems, which actually makes it somewhat difficult to put all of the findings together and ensure that wraparound can be characterized as evidence-based. Because wraparound is a real-world kind of solution to a thorny problem. It's been applied in mental health context, child welfare, juvenile justice, and systems that cross these different systems. All these different studies happen in the real world, and we're looking to achieve different kinds of outcomes across these different target populations. But we do have 9 of these studies, and if you go to the next slide there, what we found from this corpus of research is that overall, when you put the findings together, we find better functioning and mental health outcomes for youth enrolled in wraparound. We've seen reduced recidivism and better juvenile justice outcomes. Again, not uniformly, but the trends are there, and I'll show you the next slide in a second. This shows that a meta-analysis has kind of confirmed the effects overall are positive. So functioning and mental health outcomes, recidivism and juvenile justice outcomes, increased rate of case closure for child welfare-involved youth, and certainly, and probably most robustly, a reduction in costs associated with residential placements. These are some of the themes from the research. Next slide. This slide just shows the effect sizes across some of those different domains. So residential, you see effect sizes. These are all significant effect sizes from a meta-analysis we published in 2009. Biggest effects are for living situation, but you find positive, significant effects also for mental health, school, and community functioning. Next slide. But like I just said, and as that figure depicts, the cost and residential outcomes of wraparound are particularly robust. Wraparound Milwaukee, which has won many national awards, has one of the best examples, has provided some of the best examples of how to program a wraparound initiative, and has also found extraordinary reduction of reliance on institutional and residential care. Wraparound Milwaukee reduced psychiatric hospitalization from 5,000 to less than 200 days annually. They reduced the average daily RTC population in Milwaukee County dramatically. More recently, a controlled study in Massachusetts using propensity score models to look at youths involved in the MISPI program there found 32% lower emergency room expenses and 74% lower inpatient expenses than youths who are not enrolled in the coordinated care model of the MISPI program in Massachusetts. And youth spent 88% of days at home and showed improved clinical functioning in that study. Next slide. The examples just continue. New Jersey saved over $30 million in inpatient psychiatric expenditures. The state of Maine reduced net Medicaid spending by 30% for youth enrolled in Wraparound Maine, even as the overall use of services increased. 30% reduction in overall spending. There was a 43% reduction in inpatient and 29% reduction in RTC expense in that Wraparound Maine study. And Los Angeles County DSS finding that 12-month placement costs were dramatically less for wraparound discharge use compared to those discharged from residential facilities. Next slide. Finally, there was an 8-state CMS psychiatric residential treatment facility waiver demonstration project with an evaluation component. And the results of this study, which were published in 2011, and I quote, across all state grantees over the first 3 waiver years, youths maintained or improved their functional status while services cost substantially less than institutional alternatives. In most cases, waiver costs were around 20% of the average per capita total Medicaid costs for services in institutions. So next slide. So all this to say is that we see this trend in more positive outcomes from controlled research, and certainly we see this preponderance of evidence that states and counties that invest in these kinds of intensive community-based care coordination models find reduction in the expenses that tend to be accounted for by residential and institutional placements. Wraparound is increasingly considered evidence-based. We have an open review by SAMHSA's NREP project that we're contributing more information to ensure that there's a full review, but it's already been listed in the state of Oregon inventory of EBPs, the California Clearinghouse, and very recently the very influential Washington Institute for Public Policy, or WISP, found that full fidelity wraparound was worthy of being included on their inventory of research-based practices. Next slide. So here's my transition to Sheila. Full fidelity is really critical to achieving these positive outcomes. What we found is that provider staff and wraparound initiatives with more positive fidelity assessments demonstrate more positive outcomes. And our concern here is that much of wraparound implementation is in name only. They're not investing in workforce development such as training and coaching. They don't follow the research-based model. They don't monitor fidelity and outcomes. Next slide. And one of the big things is that in order to achieve full fidelity wraparound and high-quality service delivery in general, implementation requires really substantial organizational system and funding supports. So if you kind of scroll down there, Nancy, our bottom line here is that effective teams that actually implement the research-based model in a way that can get these outcomes require supportive organizations, and really relevant to the rest of today's webinar, hospitable systems, including a funding and policy environment at the federal, state, and local level that can be capable of supporting this kind of approach. It keeps kids at home, in school, and out of trouble, and ensures that we are investing appropriately in community-based services wherever possible. Go down one last slide here. So my transition to Sheila here and the topic of health homes is that if we want to achieve these things on the bottom half of the slide, such as integrated plans of care, integrated efforts that involve youth parents, providers, and natural supports, we really need to be looking to the question about how that kind of effective care coordination at the ground level extends all the way up to state legislatures, governors' mansions, certainly to the Center for Medicaid and Medicare Services, and as we'll hear now, even up to the White House and Congress. So states now have an opportunity under the ACA to create healthcare environments that can be responsive to the needs of individuals with chronic and complex conditions, including youth with serious emotional and behavioral concerns and multiple system involvement. And with that, I turn the virtual lectern over to Sheila Pyries of Human Service Collaborative to talk about health homes.
Thank you, Eric, and hello to everyone, and thank you for listening in today. And I also want to thank the National Wraparound Initiative for hosting this webinar. I'm going to talk about health homes and the intersection with high-quality wraparound and intensive care coordination. But I kind of want you all listening in to think of this as maybe food for thought. The Federal Centers for Medicare and Medicaid Services have not, as you probably know, have not issued regulations yet governing health homes. They've issued some guidance to the states. And I think all of the states are trying to figure out what do health homes look like for various populations. So I really want you to kind of be thinking about this in terms of the infrastructure that exists within your own states. And so I'm going to begin with this first slide. If you'll change the slide, Nancy, thanks. The Section 2703 of the Affordable Care Act is the health home provision. It authorizes health home services for Medicaid enrollees who have chronic conditions, which is important, and I'm going to return to that in a moment, but it makes a health home different from a medical home. And I'm going to return to that issue in a moment as well. The provision authorizes 90% federal match for the first 8 quarters of health home implementation, so that's a nice incentive for states to implement health homes. And they're designed to facilitate access to and coordination of not only medical care, but behavioral health services as well as long-term community-based services and supports. And the goal is to improve the quality and cost of care as well as enrollees' experience with care. So health homes are looking to reduce the use of, for example, expensive inpatient, hospitalization, emergency room use, in the case of children, the use of psychiatric residential treatment facilities. And these are, as Eric just pointed out, very similar goals to high-quality wraparound and intensive care coordination models, which have produced decent outcomes around quality and cost. So moving to the next slide, some of the terminology with health homes gets a little tricky when we talk about children with serious behavioral health challenges, because we don't usually use the language of chronicity or long-term care, partly in a recognition that children are still developing and that even serious behavioral health challenges in children can often be resolved. And also in terms of long-term care, we don't think of necessarily a lifetime need for services in children, although certainly there is an important subset of youth that do transition to adult mental health systems. But the average length of stay in a wraparound, high-quality wraparound, intensive care coordination models out there tends to be about 16 to 18 months. So, but the way that children who use behavioral health services in Medicaid, that population, the way they use services, the cost of those services, the types of services, really does make them a, quote, chronic population. And CMS has recognized that. So the language in the legislation is that to be eligible for a health home, you have to have at least 2 chronic conditions, or 1 chronic condition and be at risk for another, or have 1 serious and persistent mental health condition. States may target health home services to those with particular chronic conditions or with a higher severity of chronic conditions, but you cannot target by age. So currently, CMS's policy is that if a state is going to submit a health home state plan amendment for populations with serious mental illness, it must include both adults and children. You can't just do adults with serious and persistent illness or just children with serious emotional or behavioral health challenges. The health home provision does waive Medicaid comparability, which means that you can offer health home services in a different amount, duration, or scope than offered to individuals who are not enrolled in the health home. And you may also target by geographic area. CMS has also clarified that the 90% enhanced federal match starts anew with a new geographic expansion for the same population or for a different population. So the prohibition is that you can't collect more than 8 quarters of 90% enhanced match for the same enrollees. But if you're expanding geographically, as a new geographic area kicked in, it could start anew. Looking at the next slide, I want to talk a little bit about the difference between health homes and medical homes, because health homes are intended in some respects to build on the medical home concept, certainly for certain populations. Medical homes, though, are really geared toward all children. I mean, all children need a medical home. I mean, you can argue that all individuals need a medical home, but children in particular. And health homes are designed for children with chronic conditions, so children with serious behavioral health conditions. Medical homes historically have coordinated medical care, and health homes are designed, as I noted earlier, to coordinate across physical and behavioral health care as well as social services, social supports, etc. Medical homes have typically been physician-led primary care practices, and as Diana will talk about in more detail later, health homes may be different types of specialty provider organizations, including behavioral health specialty organizations, and not only medical providers. Another way of thinking about this is, for example, you could create a medical home for the foster care population, which, as we know, uses a lot of services, and that's something that Wisconsin is doing. But you can't create a health home for the foster care population, because health homes are designed for populations with certain chronic conditions. So you could design a health home for children with serious behavioral health challenges, and of course, probably 2/3 of the enrollment would be children involved in child welfare. So you'd be designing it as a health home for children with serious behavioral health challenges. Going to the next slide, there was an interesting analysis done of medical home services for children with behavioral health conditions. And what it found is that, with the exception of ADHD, which is often treated in a primary care practice, all other behavioral health conditions were associated with difficulties in accessing specialty care through medical homes. And the reason suggested is that as to why behavioral health conditions other than ADHD weren't particularly consistent with the medical home model as it's historically existed, it has to do with difficulty in accessing specialty behavioral health care rather than with accessing quality primary care. And that's an important thing to consider as we move along here and talk about why children with serious behavioral health challenges in fact look like and really are a distinct population from adults with serious mental illness. Even though CMS is saying you have to do both populations, it's interesting because children with serious behavioral health challenges really are distinct from adults. So let's go to this next slide and look at some of the reasons why, in addition to kind of the issues of chronicity and long-term care that I talked about earlier. Children with serious behavioral health challenges simply don't have the same high rates of comorbid physical health conditions as do adults with serious and persistent mental illness. In addition, for the most part, and let me just say something too. It's interesting because Missouri, as many of you know, was I think maybe the first state to have, and there aren't too many yet, just a handful, to have a state plan amendment approved by Medicaid, by CMS, for a health home for persons with serious mental illness, and it is serving both adults and children. And they noted on this webinar the other day that the driver of cost for the child population is behavioral health care, whereas for adults the driver of cost is medical care. And that's corroborated by a national study that we did that I'll talk about in a moment. So that's an important issue. Secondly, it's important that children's diagnoses tend to be pretty different from adults with serious and persistent mental illness, where you see, for example, children with ADHD, with conduct disorders, with anxiety, and not so much, schizophrenia, psychosis, bipolar, as you do in adults. Among children with serious behavioral health challenges, you could expect that probably 2/3 of them are also involved with child welfare and or juvenile justice systems, and maybe 60% are involved in special education. And these are systems that are governed by legal mandates and, in addition, make decisions that influence, often, service provision and the treatment provided by children. So in order to coordinate care for these children, health homes truly cannot ignore these other systems. And so what happens is that the coordination that takes up most of a care coordinator's time when it comes to children with serious and complex behavioral health challenges is not the coordination with primary care, it's the coordination among behavioral health providers and with these other systems like the schools, child welfare, juvenile justice. And a final reason, and I'm sure you can also think of others, is that in order to improve the cost and quality of care for children, the focus has to be on both the child and youth and the family or caregivers. And that creates a complexity to care coordination. That, and I think the systems involvement that I mentioned earlier, creates a complexity which is why you see some of in a high quality wraparound intensive care coordination approach, very low case ratios of 1 to maybe 8 to 10 children and families. That's quite different from health home models that have been proposed, for example, for adults with serious mental illness, where the case ratios tend to be a care coordinator for 250 adults. So that's an important consideration. In addition, some of you may have seen that CMS recently issued a letter to Medicaid directors about the quality measures that they are recommending states track in health home provision. And the initial quality measures that CMS sent out are aligned with the initial core measures that they've developed for adults in the Medicaid population. So most of them are more adult appropriate. Diana is going to be talking about translating quality measures in a children's environment when she talks, so I won't say any more about that, but I think that's another important issue, the quality measures, the systems issues, et cetera, that tend to be tracked to say this is a quality initiative that produces better quality and cost. They tend to be a little bit different than what you track on the adult side when it comes to children. So when we go to the next slide, I want to talk just a little bit about this national study that the Center for Healthcare Strategies did, that we did with the center on looking at 29 million children. That's the total child Medicaid population. And we looked at children in Medicaid who use behavioral health care and what types of services they use and the cost of those services. And as Eric mentioned, about 9.6% of children in Medicaid use behavioral health care, and by that I mean both behavioral health services and psychotropic medications. And that accounts for about an estimated 38% of all spending for children in Medicaid. So it's a total of a little over $19 billion in spending, about $1.6 billion of which is on psychotropic meds. If you go to the next slide, Nancy, you'll see mean expenditures for this population of children, this nearly 2 million children in Medicaid who use behavioral health care. And you can see how their average expenditures are very high. I mean, they're about, if you look at the 8,520 mean health expenditures that used by this population, that's about 5 times the mean expenditure of a Medicaid child who does not use behavioral health care. And then, of course, if you stratify expenditures by aid category, as you would expect, you see the foster care and SSI populations with children with much higher expenditures, average expenditures. And while the TANF population's average expenditures are a little bit lower, they're still quite a bit higher than children in general in Medicaid. And because the TANF population represents, about 92% of children in Medicaid, you can't ignore the TANF population when you're doing customized approaches for children with serious behavioral health challenges, because there are a fair number of children in the TANF population who have serious challenges. Even this far right-hand column, the top 10% most expensive children who use behavioral health care, you can see that their costs as well are driven by the use of behavioral health services, not so much by primary care, although they're using a lot, or by medical care rather, they're using a fair amount of that though as well. Just to give you a point of comparison also, the Missouri Health Home Initiative for adults and children with serious mental illness They are focusing on Medicaid consumers with at least $10,000 in Medicaid costs. So you can see how this population of children who use, and this is all children in the Medicaid population who use behavioral health care, how they are a very high-cost population. Going to the next slide, I just want to say that if you look at what the top 3 highest expenditures are for this population, the highest is residential treatment and therapeutic group care, representing over 19% of expenditures for about 3.6% of children. And then a third highest is psychotropic meds, and 42% of the expense associated with psychotropic medication cost is represented by the use of antipsychotics. So there's real opportunity, because you can use your Medicaid claims data to look at where are our high-cost populations of children and what are they using, to really drill down into who should be our health home populations. Okay, next slide. So customizing health home approaches, the states may submit, now I'm talking now states that want to do state plan amendments, health home provisions for persons with serious mental illness. They can do one state plan amendment that incorporates 2 distinct approaches, one for children and one for adults, or they may submit 2 separate health home state plan amendments, one for adults, one for children, but the clock starts on the 90% federal match with the first one approved. Unless, as I mentioned earlier, you're just starting in one geographic area, and then you can move into additional geographic areas. All right, going to the next slide, I want to say just a little bit about the Children's Health Insurance Program Reauthorization Act authorized CMS to make a number of quality improvement grants to the states, and we're involved in one that is implementing a care management entity approach that in the 3 states are Maryland as the lead, Georgia, and Wyoming. And it really is utilizing high-quality wraparound and intensive care coordination using provider specialty organizations, in effect, to improve the quality, outcomes, and cost of care. And for children enrolled in Medicaid and SCHIP that have serious behavioral health challenges. Now, I'm going to talk for a moment about care management entities, but those of you that you may also be thinking about this as a high-quality wraparound team that's embedded in a supportive organization, such as Oklahoma is doing, which I'll return to in a moment. So going to the next slide. The functions of a care management entity at the service level are the child and family team care planning and oversight that Eric referenced using a high-quality wraparound practice approach. Screening, assessment, and clinical oversight, and often states are using a standardized screening and assessment tool, such as the Child and Adolescent Needs and Strengths tool, the CANS. Intensive care coordination at low ratios, care monitoring and review, access to peer support partners, family and youth who have lived experience, and access to mobile crisis supports. It also helps a great deal if your Medicaid benefit, particularly through the rehab option, is a flexible benefit that provides access to home and community-based supports. That's been a hallmark and tenet of the system of care approach for over 20 years, and particularly in managed systems, you don't want to constrain the benefit. You want to try to have access to a flexible array that then can be managed, both at a child level and at a population level. So at the administrative level, a care management entity either directly is doing these functions or in partnership. So it may be partnering. It may be that you have a statewide administrative service organization or managed care companies that are already playing these roles. They already have an IT system that you can build on. They're already doing some level of provider network recruitment and management. So these can be shared functions. They can be done directly by a care management entity or in partnership. The next slide, please. Wraparound Milwaukee, I won't say a lot about. It is probably the oldest enduring model of a care management entity, and as Eric said, was honored by Harvard's Innovation in Government Award in 2009, and they do have very good outcomes. They're an example of a multi-payer system where Medicaid and other child-serving systems that spend dollars on these populations of children are contributing. That's another point that can be made about medical homes. Medical homes when they talk about multi-payer systems, are typically talking about drawing on commercial insurers and Medicaid. Health homes, are really at the moment a Medicaid thought and are drawing on perhaps some other public payers, and could in time become something that commercial insurers would buy into. But commercial insurers haven't really had the responsibility, frankly, for managing care for children who have serious and complex behavioral health challenges. That population, of children and families has really had to rely on the public sector. So it's be interesting to see how this evolves over time. But you see the multi-payer systems in Wraparound Milwaukee. You see the all-inclusive case rate, and these models typically do use population-based case rates. And by the way, health homes the health home provision allows you to utilize bundled rates or case rates. You can use tiered payment rates. You can operate within a fee-for-service or capitated environment. CMS is really looking for innovation and trying to provide flexibility to states. So again, be thinking about what is the infrastructure in my own state that we could build on. And you see their all-inclusive rate here of, and this is everything, of about $3,700 per child per month. And if you disentangled the care coordination rate from that, it's about $780 per child per month. If you go to, and the peer supports are outside of that rate, so that's just the care, are outside of the 780, so that's just the care coordination rate. So we go to the next slide, and I'm going to show you 3 examples in the next 3 slides of states that have taken this concept statewide. New Jersey being the oldest, and they have what I would call a children's behavioral health carve-out, in which Medicaid is the single payer system, and the policy oversight is a partnership between the Department of Children and Families and Department of Human Services Medicaid. They have used multiple public payers, and there is a statewide administrative service organization, a contracted systems administrator, and then locally based care management entities that have this role of managing care for high-need populations of children with serious behavioral health challenges. Their care coordination rate runs about $1,000 per child per month. If you go to the next slide, Louisiana is a somewhat newer model. They started in March of last year. They're a behavioral health carve-out for adults and children operating under a 1915B and 1915C waivers. They too have a statewide administrative service organization. Magellan has that contract. And they have regionally based care management entities doing the exact same functions as the care management entities in New Jersey, for example. And they partner with family-run organizations, as do, which I should have said earlier, the New Jersey care management agency entities do as well. They partner with family-run organizations. And the care coordination rate in Louisiana is fairly similar to that in New Jersey, about $1,000 per child per month, with, again, family peer support being outside of that rate, as it is in New Jersey as well. In Massachusetts, a third example, there are 5 managed care entities in Massachusetts operating under an 1115 research and demonstration waiver, and they created locally based care management entities, which they call community service agencies. They are nonprofit behavioral health and specialty providers, as they are in New Jersey and Louisiana as well. They are doing, again, the same functions. And while Massachusetts does not use a case rate or a bundled rate at the moment, if you, for comparative purposes, if you assume the productivity standards that I have down here on the slide, which is what Massachusetts did assume, and the average caseload of one care coordinator to no more than 10 children, their 15-minute rate translates or suggests a per child per month rate of about $1,100 to $1,200 per child per month. Okay, so moving to the next slide. I'm not going to go into a lot of detail on this next slide. It's a little dense. But what we did was actually what Suzanne Fields did, who is now the healthcare advisor to the administrator, Pam Hyde, at Substance Abuse, Federal Substance Abuse and Mental Health Services Administration. Prior to her going to SAMHSA, she had done this comparison between the health home provider standards on the left, which come out of the legislation and guidance, and care management entity activities on the right that are using a high-quality wraparound intensive care coordination approach. So you can kind of compare those at your leisure. Going to the next slide, the core health home services in the health home provision are these comprehensive care management, care coordination in health and behavioral health promotion, transitional care across settings, individual and family support services, linkage to social supports and community resources, and use of health information technology to link services and enhance communication. The bullets underneath each of these in italics are again kind of food for thought that are on how to translate these to what makes sense for children with serious behavioral health challenges. And so, for example, if you look at transitional care across settings, which include follow-up for inpatient and facilitating transfer from pediatric to adult systems, for children, obviously, other out-of-home treatment settings are important. Residential treatment, therapeutic foster care, and there are unique youth transition issues because youth with serious behavioral health challenges who are transitioning to adult behavioral health systems may also be transitioning at the same time from foster care, from juvenile justice systems, from special education. So there are kind of a complexity of transition issues, if you will. Individual and family support services. Many states now have very good family and youth-run organizations, that's families and youth with lived experience, to provide peer support. Many of them, like Maryland, have certification for family peer support providers and are partnering with their family-run organizations. Diane is going to talk about a matrix that the center put together on all of the states that are now covering family and youth support as a Medicaid service, and so that's a, sort of easily translatable, I think, for health home provision, and so again you can kind of look at this as you have time. The next slide is a kind of rough picture of Oklahoma, which is planning a health home state plan amendment, where they have invested resources through various systems of care grants, et cetera, over time in building high-quality wraparound teams that are embedded within their community mental health centers. And so they're doing a health home spa that has two approaches, both embedded within a community mental health center, but on the adult side, they'll be using a nurse care manager, an ACT team, adult peer consumer as their core, whereas on the children's side, they'll be using the wraparound facilitator and doing intensive care coordination and family and youth peer support. So that's an example of a state that is using its infrastructure, its existing infrastructure that they feel will work best for children with behavioral health needs as a health home approach. And okay, so, and Diana, by the way, is going to be talking about provider types in health homes, and they basically come down to three: a designated provider entity, a team of healthcare professionals, or a health team. Oklahoma is going with the team of healthcare professionals route, and the core of it for children is this high-quality WRAP intensive care coordinator approach with family support, peer support. Okay, next slide. Some of the issues I think to think about when you're looking at how to build on infrastructure, existing infrastructure, create new infrastructure, using high quality and wraparound and intensive care coordination, is the coordination with primary care, which you have to address in a health home, and you really should be anyhow. So you would want to ensure that either your care management entity or your wraparound team of healthcare professionals is charged with ensuring that every child has an identified primary care provider. So for example, in Wraparound Milwaukee, the plan of care developed by the child and family team it is not approved unless the child has a primary care provider identified, and there's communication with that primary care provider to let him or her know that the child is enrolled in the health home, inviting opportunity to participate in the child and family team, ensuring that the primary care physician has the child's plan of care and is informed of changes. You want to make sure that the child is receiving EPSDT screens on schedule, that the child has an annual well child visit, and particularly if the child is on psychotropic medication, that there is that communication and coordination with the primary care provider and monitoring for metabolic issues such as obesity and diabetes that are risks of some of these psychotropic meds. So I'm sure you can think of even additional ways of ensuring coordination with primary care that would, I think, make the life of a primary care provider who is serving children with serious behavioral health challenges, would make it much better to lodge these kinds of functions within a health home that's customized for these children. In other words, a behavioral health specialty provider or some other specialty provider that has experience with these children, serving these children and families. Okay, the next slide. It is important to ensure that the health home functions don't duplicate those of other management entities. So you can't bill twice for the same functions. So for example, many of you may already have patient-centered medical homes, you may have managed care organizations, you may have targeted case management providers who are doing some of these functions. And I'd really encourage you to develop matrices that show the distinct functions of each and what the health home would be doing distinct from these. I think that's relatively easy to do, or easier to do when it comes to the patients that are in medical homes and what they're doing, because they are primarily coordinating medical care, which the behavioral health specialty, health home isn't necessarily going to be coordinating all the medical care. The medical home would be doing that. Managed care organizations may be supporting some of the IT functions. They may be doing, for example, enrollment or outreach or identification of populations that are potentially eligible for a health home, and that could be done by your managed care organization. So those are functions that I think are more easily distinguishable. I think in the children's world, where some of the more difficulty comes up is with targeted case management, and these are a few options that we've been thinking about to avoid duplication with targeted case management. And one is that you could replace targeted case management altogether with a health home spa. And that might be appealing to some states where you're not that happy with your targeted case management to begin with. It's not a consistent model. There's been some, not really clarity about who the eligible population is, or some, creep on that. So that's a possibility. Or you could distinguish your targeted case management and health home populations. So you could keep targeted case management for children who are at high risk and designate the health home for children with the most serious and complex behavioral health challenges, that, top 10% or 15% most expensive children. Another possibility is that you could distinguish your targeted case management and health home functions for the same population, where really then you're seeing health home as an augmentation of targeted case management, and you'd have to be very sure that the health home rate does not include aspects of care coordination that are provided through and billed through your targeted case management function. A couple of other things that are important to ensure in the next slide is that the rate sufficient. If you are going to have a care management entity or a wraparound team that is the health home, and it's not necessarily an augmentation of a targeted case management provider, let's say, but it is the health home, it is doing everything, then you really need to look at the sufficiency of the care coordination rates, because the rates that you tend to see in the handful of health homes that have been approved so far, they're much lower. The Missouri rate, for example, is about $78 per member per month, which is really kind of more of an add-on rate. And Diana will talk about a resource that again, we developed in the center around case rates in these types of approaches. I want to kind of end with some lessons that I think interestingly came out of an adult approach, but it was New York's Chronic Illness Demonstration Project, and it's a publication that the Center for Healthcare Strategies recently issued, and it's lessons for Medicaid health homes. And there are really a lot of the things that we've been saying about when you implement high-fidelity wraparound and intensive care coordination, what you have to do anyhow. And so I found this interesting, that they're saying you have to establish much closer connections at the outset between the organizations that are responsible for care management and providers. You have to address the data sharing issues and needs, and that's really even more important in the children's world, or it's more complex, I should say, because of the involvement of these other systems like child welfare and the schools, etc., in addition to Medicaid. You have to ensure reimbursement for locating and enrolling your population of focus, your high-risk, high-cost enrollees. And again, that could be a function if you're already operating in a managed care environment. Maybe that's a function for your managed care organizations to undertake. Or it could be a role of the health home. Extensive education to build good relationships among organizations. And again, as Eric noted in his presentation, and Diana will no doubt reference as well, as these lessons said, given the intensity of the job, that it was difficult to hire the right people to do community-based care management, and there was considerable turnover. And if you look at high-quality wraparound intensive care coordination approaches, like a Milwaukee, you're struck by how little turnover there is, and they invest in workforce training, in coaching, in capacity building that prepares care managers to do this kind of patient-centered, or we would say child and family-centered care management, and a particular emphasis on the importance of training peer support specialists. And I think there's an increasing body of literature, I wish there were more, that showed the importance of having family and youth peer partners as part of certainly the high-quality wraparound intensive care coordination approach, but I think in the future in health homes as well. So if we skip from the next slide, which is this contact info, to the poll question, we have this poll question that we thought would be of interest. Is your state doing a health home for persons with serious mental illness, and does it incorporate high-quality wraparound for children? And so if you want to take a moment to look at those answers and answer them. And Nancy, I'm going to have to ask you all to, I don't know what the answers say, so I'm going to leave it to you all to, there we are, thank you. So, it's interesting, we have close to half of the listeners on this call who don't know whether your state's doing a health home. So I think it's really important that you find out. State Medicaid agencies don't necessarily know about these particular approaches that we're talking about. It would be good to communicate and share data, etc. We see about 14% that says yes, we're doing a health home, and it incorporates high-quality wraparound. Okay, I think we'll see more of this happening as we move along over the next year or so. All right, I'm going to turn now to Diana Simons from the Center for Healthcare Strategies.
Thanks, Sheila. I hope everyone can hear me. Thanks for listening this afternoon, and thanks to the National Wraparound Initiative for the opportunity. I'm a Senior Program Officer at the Center for Healthcare Strategies and the Center's Project Coordinator for the CHIPRA Care Management Entity Collaborative, which Sheila talked a little bit about. I'm also a licensed mental health counselor. My background is in children's behavioral health, managed behavioral health care, and systems of care, so I'm very excited to be talking with you today about the potential for serving children with complex behavioral health needs in their homes and communities in quality and cost-effective ways. Next slide, please. My goal this afternoon is to give you some background on the Center's work, the three-state care management entity collaborative, for which Maryland is the lead grantee and is partnering with Georgia and Wyoming, and to review some of the Affordable Care Act language and present some resources that the Center has developed to support our states that might be useful to you as you explore the viability of customized health homes in your own state. Next slide, please. For those who are unfamiliar with the Center for Healthcare Strategies, we're a national nonprofit resource center that works with states, Medicaid agencies, and health plans to improve the quality and cost effectiveness of publicly financed health care and to reduce disparities for low-income families and individuals with chronic illnesses and disabilities. The quality improvement framework that the three states in the CHIPRA Care Management Entity Collaborative are using to guide their project planning activities and that also serve as the independent evaluation of the collaborative has been used by CHCS in close to 20 learning collaboratives. The framework was developed by the Center in 1999 to improve the quality and cost effectiveness of Medicaid managed health care, and some of you may know it as BCAP, Best Clinical and Administrative Practices. This is the first time the framework is being adapted for use on a systemic scale, but since it's a continuous quality improvement approach, it's applicable in various settings and to various processes. It provides a really deliberate planning and implementation process that's driven by data and supported by documentation, and it requires a goal-specific, quantitatively measurable approach that enables one to make clear, supported statements about the impact of the intervention, in our case, the care management entity model, on aspects of care and costs that states and the federal government are focused on. Next slide, please. So what's the project? The Children's Health Insurance Program Reauthorization Act of 2009, also known as CHIPRA, contained language for a number of 5-year demonstration grants to states to improve the quality and care for children and youth enrolled in Medicaid and CHIP. CHCS sought out a partnership with a number of states to apply for one of the 10 demonstration grants, and in February 2010, Maryland, in partnership with Georgia and Wyoming, was awarded a CHIPRA quality demonstration grant by the Centers for Medicare and Medicaid. We're collectively known as the CHIPRA CME Collaborative. We're the only grant project with a primary focus on children with serious behavioral health challenges. Most of the other grantees are focused on patient-centered medical homes and the development and or testing of the pediatric core measures. The states in the collaborative all share the common goal of improving clinical and functional outcomes, access to home and community-based services, cost outcomes, and family and youth resiliency for children with severe behavioral health needs. They're working to achieve this by either implementing or expanding a care management entity model, or CME model, as we refer to it, in their respective states. And they're all addressing how to integrate the CME approach into the larger Medicaid delivery system in an environment of Medicaid redesign and health reform. At the beginning of the grant, Maryland had 2 vendors for CMEs in 3 regions of the state. As of July 1st of this past year, 1 CME now covers the entire state with 1 vendor. Georgia had 4 CMEs that were developed through their PRTF demonstration waiver and currently has 2 CME providers. And Wyoming has never actually had a CME, but the state has developed a design and is pending implementation of their first CME later this year, which will initially serve 25 youth in the southeastern region of the state, with a plan to increase that number to 100 by the end of the grant, which ends in 2015. I should have mentioned that we are entering the 4th year of the grant this month. Next slide, please. CHCS is the coordinating entity and lead technical assistance provider for the 3 states in the Care Management Entity Collaborative. This is a really busy slide that outlines CHCS's role. In addition to project coordination, the independent evaluation, and developing the quality framework I mentioned before, it's our role to provide the states with tools and resources to help them succeed both in their identified state goals and their common goal of implementation or expansion of a CME approach serving children and youth with SCD. I'm going to focus in particular on 3 resources. They're in bold on the slide. That we've developed over the past year that have helped our states to think through their designs and the decisions around implementation, refinement, and expansion they're engaged in within the context of the Affordable Care Act and healthcare reform. I'm not going to talk about them today, but our webinar series are also a great resource that provide detailed information on various aspects of CME planning and implementation with examples from the field on financing CMEs, the role of mobile response and stabilization, etc. Next slide, please. Before we get into the CHCS developed resources, I wanted to take a few minutes to walk through some of the Affordable Care Act language on provider standards and infrastructure. All of this information, by the way, was in the November 2010 CMS State Medicaid Director Letter. It's available on the Medicaid.gov website under Federal Policy Guidance. And I think we're going to provide the NWI with just a resource list for websites when we're done with this, so that will go out after this webinar, so you'll have all those resources. I won't go through all of the provider standards today. They appear in the left column of Sheila's slide that shows the potential of CMEs as health homes. I think she referred to it as Suzanne Field's slide. The standards require states to describe in the state plan amendment how they're going to support health home providers in addressing key components, and those are the key components on that slide. But the last box on the Sheila's slide references the collection and reporting of data, and that's language you see on this slide here. Related to that, I just wanted to reiterate what Sheila has said, that CMS released guidance on the recommended measures for health homes last week, and the guidance is clear that although these measures are not yet required, CMS intends to make their use mandatory soon. The guidance is online at the address that you see on the slide right now. There are 8 data elements. Many can be evaluated through claims, but some will require more intensive data collection, and data collection will require partnerships between health homes and other entities such as managed care organizations. The 8 measures apply to both adults and kids. Many are clearly more adult appropriate, like controlling high blood pressure, for example. But some of the measures that are more applicable to children include follow-up after hospitalization for mental illness and care transition. Next slide, please. So the ACA describes 3 distinct types of health home provider arrangements. There's designated providers, there's a team of healthcare professionals, which links to a designated provider, and a health team. Next slide, please. Section 1945H5 of the ACA includes examples of providers that may qualify as a designated provider. You can see them on the slide here. An important takeaway is that this is not an exhaustive list, and states can include other providers in this category, including other agencies that offer behavioral health services. States need to describe all designated providers in the state plan amendment application, which is subject to CMS approval, and each designated provider must have systems in place to satisfy certain qualification standards. There's clearly some flexibility in the types and entities that can be designated providers. There was a SEMSA HRSA webinar last Friday that I think Sheila had alluded to on operationalizing behavioral health homes. It's part of the Center for Integrated Health Solutions that referenced behavioral health homes as an opportunity for mental health and substance use providers. We actually see this opportunity as broader and with the potential to include care management entities as well. The webinar reviewed some key action steps for becoming a behavioral health home, like working collaboratively, involving stakeholders, forming and maintaining community partnerships, establishing relationships and linkages with state agencies. And for CMEs, these are several things that they're already doing and doing well. So it seems a natural fit. Next slide, please. Section 1945H6 contains examples of the providers comprising a team of healthcare professionals, but that's not an exhaustive list either. Sheila mentioned that Oklahoma is pursuing this option for their health homes. And teams of healthcare professionals can operate in various settings. The state plan amendment the application needs to include a description of the composition of these teams, but as you can see, it's certainly a flexible option. Next slide, please. The health home section of the ACA defines a health team to have the same meaning as health team in the section on establishing community health teams to support patient-centered medical homes, which basically requires the secretary to define the health team, but also indicates that the team should be interdisciplinary, interprofessional, and that the definition must include the providers shown on this slide. The state Medicaid director letter indicates that CMS is interpreting the statute to allow states to choose which provider arrangement or arrangements to offer, and if more than one option is offered, that the beneficiary can choose among the options. They also recognize that there's diversity in provider arrangements across states. And whatever option or options states select, the federal government's expectation is that the state will embed the criteria described in the provider standards in its provider qualifications and be accountable for providers adhering to and upholding the standards both initially and in an ongoing way. Next slide, please. So getting back to the resources that we wanted to highlight for states considering using Medicaid health homes with wraparound to serve children with complex behavioral health needs. I'm sorry that this slide is not more clear. This document that you see here, the first page of it, using CMEs for behavioral health home providers sample language, was published last October, and it was created to help the states participating in our collaborative think through key elements of a health home for children with serious behavioral health challenges, using CMEs as designated providers for specialized populations. It can help state Medicaid agencies articulate how CMEs may serve as designated health home providers for children and youth with serious emotional disturbances. And the language could potentially be used in the context of a broader SMI-SED state plan amendment as described in the ACA. It includes recommended language, references to the ACA provisions, and state examples in comment boxes, like that blue box you see there, throughout the document. It's structured in the old CMS online submission format, and it borrows language from the two states that had approved health home spas at the time, Rhode Island and Missouri, and is actually adapted to the CME based on Massachusetts performance specifications for intensive care coordination and family support and training, since both of those were CMS-approved services, standalone services. CMS just recently came out with a new, friendlier online submission format, and we will be using that for our next iteration of the guidance on using a team of healthcare professionals, which we hope to have completed in the near future. The disclaimer on all of this guidance is that it's not intended either to suggest or ensure the approval of health home spa by CMS, and health homes, as Sheila mentioned, may not be targeted by age, so care management entities represent one approach to behavioral health homes that would likely need to be launched in tandem with other models that may more aptly address the needs of adults with behavioral health needs. Next slide, please. This slide is just an example of some of the customized language in the document. This particular section is on health promotion. The CME-specific definition references the individual care plan and the use of care coordinator or family partner to perform the task, but the functions are consistent with health home functions under health promotion in general. There's a typo on this slide. There shouldn't be two number 4s. Addressing and encouraging activities related to health and wellness should be number 5. Sorry about that. Next slide, please. I spoke earlier, and Sheila mentioned the 8 measures released last week by CMS. Goal-based quality measures are required for health homes, but beyond the 8 core measures, measures can certainly be customized. This is an example of adapted language related to the goal of improved functioning, which actually references the CANS, the Child and Adolescent Needs and Strengths Evaluation Tool. And the next slide is a screenshot of the sample-specific measures, data sources, etc. Next slide, please. So on this slide, you can barely see that for the goal of improved functioning, clinical outcomes can be measured by the CANS. Experience of care could be measured by the resiliency module of the California Healthy Kids survey, and quality of care could be measured by the Wraparound Fidelity Index. Next slide, please. Another resource we developed to support the work of the states in the CHIPR Collaborative is the case rate scan for CMEs, also published in October of last year, which is meant to guide those who might be exploring the CME model and looking to learn more about ways to structure case rates within the model. Sheila spoke about the importance of ensuring the sufficiency of rate. Financing strategies for CMEs necessarily reflect the fiscal realities of the locality the CME serves and vary considerably from one place to the next. So one important way in which they're funded is through case rates, and several types of case rates are used in funding CMEs exist across the country. The scan that we did summarizes how CMEs in 8 states have structured their financing approaches. As you look at this document, it's important to look at what is contained in the rate. Case rates used in financing CMEs may be limited to funding care coordination only, or may include any or all of the core components of the CME model, including family and youth peer support, wraparound care planning and services like home and community-based services such as inpatient psychiatric hospitalization, in-home therapy, psychiatric residential treatment. An all-inclusive rate, for example, would cover all of the components and include the cost of all services and supports as well. Next slide, please. Finally, the last resource that we wanted to share today is a scan of states using Medicaid to finance family and youth peer support. Family and youth peer support plays an essential role in helping to build the resiliency of caregivers and youth and strengthen the capacity of families to care for kids at home. Providers of family and youth peer support are integral to teams serving children and youth with behavioral health challenges and their families, and they're distinct from traditional mental health service providers in that they operate out of their lived experience and knowledge. The idea for this scan came out of a conversation we had with at one of our collaborative meetings, which take place 3 times a year. These meetings allow for intensive individual state team and cross-team facilitated discussion and learning. Anyway, at one of these meetings, the family leads from each state had just presented on the family and youth peer support in their respective states, and the lead on Maryland's CHIPR team observed that it would be good to know what other states were doing. So we reached out to the National Federation of Families, who provided us with their broader list of parent peer support, and with the Institute of Innovation and Implementation at the University of Maryland over a series of phone exchanges, extensive internet research of state government websites, many calls and emails to state Medicaid agencies. We developed a scan of states using Medicaid to finance family and youth peer support. It's organized by state and Medicaid funding source and includes the service, title, definition, components of service, etc. The information was drawn primarily from state government websites, and to the extent possible, state-specific Medicaid and regulatory language was used. It contains information on 8 states that cover family and youth peer support as a state plan service and 7 that cover it as a waiver service. Next slide, please. We consider the scan useful because, as we've said, CMEs are not a cookie-cutter approach. They can look very different from one another depending on where they are, who they serve. Regardless, though, we have our bottom line. All CMEs provide some or all of the core components that I mentioned before and are on this slide. From our perspective, the 3-legged stool of a CME really requires intensive care coordination, wraparound care planning, and family and youth peer support. Without these first 3 components, and as Eric mentioned earlier, fidelity to the wraparound care planning process, it's unlikely that good outcomes can be achieved or sustained. Going back to the Samantha Hursa webinar from last Friday, the competencies that they discussed related to workforce development for behavioral health homes, things like care coordination, linkage, etc., are really a good natural match to what care coordinators and family partners already do. Next slide, please. The scan of family and youth peer support is available, as are all the resources I've described, on the CHCS website under the Resources tab in Children's Health. I also wanted to mention, for those who are familiar with the ICRC website, that state technical assistance resources for health homes are transitioning to a new home. There will be a formal announcement coming soon, but as of January 12th, health home materials have been moved to the Health Home Information Resource Center on Medicaid.gov. It's the same team and same technical assistance offerings, including the webinar series, but it's got a new name and a new URL, so stay tuned for that. ICRC will continue to provide state technical assistance for Medicare and Medicaid integration. So with that, I'm done, and I think we've got a few minutes for questions if there are any.
Thank you, Diana. And yes, we do have a few minutes for questions. Sheila, I'm wondering if you've had a chance to take a look at the questions that people have submitted and pick out one or two that you think maybe typifies the kind of questions that you get when you are covering these topics with other audiences.
Okay, so one question was, what does the 90% federal match at what services does that apply to? And it applies to the designated health home services, the list that I mentioned on my slide, and not to other Medicaid services. And you also, again, have to be careful that you're not billing for some of those core health home services in some other arena, like, for example, targeted case management or in a patient-centered medical home. So you have to look at the intersection between the two, but the 90% match applies to those health home services. Somebody asked what's the difference between an ACO and an accountable care organization and a care management entity. Think of a care management entity as a specialty provider organization, typically serving relatively small numbers of children who are children using a great deal of services and who have high needs. An accountable care organization has to serve at least a population base of 5,000 people. It's typically the hub for it. It's typically a hospital-based system, and it's focusing on all populations, not only those who have, quote, chronic conditions. Another quick question was the source of data on children having less high rates of comorbid chronic physical conditions as adults. Both a 2003 SAMHSA study using the Medicaid MAX data, which is all of the Medicaid data, as well as the FACES study that's referenced on my slides, which will be available soon on the Center for Healthcare Strategies website, found the same thing. What we found is that maybe a third of the population of children who use behavioral health care have serious medical issues, typically things like asthma. Whereas adults with serious and persistent mental illness, it's about 68% of the adult population that have comorbid physical conditions like diabetes, heart disease, chronic obstructive pulmonary disease, etc. So very different look there. What is a serious behavioral health condition? Somebody asked whether you could identify that based on provider judgment or diagnosis. Diagnosis tends not to be reliable for identifying serious behavioral health conditions, nor do you want to necessarily rely on individual provider judgment, because there's a lot of variability. States tend to use standardized tools like the CANs, and a combination of that and cost, just as Missouri is doing, for example. I think I probably better stop because it's 3:30. Is it?
It is indeed, and thank you for getting so efficiently through a number of those questions. I think we did get through a lot of the questions. Also, we did chat answers to a number of people, and we will be posting the entire webinar, including slides alone and the recorded version, on the website within a matter of hours, I'm sure, from now. And you can feel free to contact the NWI if you have further questions. So does anyone else have any final comments they want to make before we sign off, any of the panelists?
Janet, some folks asked if some of these CME documents and links to that kind of TA would be also available through the same link on the NWI website.
Right. So I think what we decided was we will post a companion document that gives information about the websites and how to get the other documents that were noted in the webinar, so that people can easily access those by coming to the NWI website.
Okay, great. Thank you.
Okay, so we'll just look for that information from Sheila and Diana, and we will post that. Okay, well, thank you to everyone, particularly our presenters, for doing such a fabulous job with a lot of very important and complicated information. And thank you to everyone who joined us. We hope you will join us again in the future, and have a great day. Bye-bye.
Thank you. Bye.
Thank you, everyone.
Bye-bye.